Today's business. Today we're going to talk about economics and science fiction, and some would say these are often the same thing. We'll be talking about economics because we'll be talking about supply and demand for healthcare. We'll be talking science fiction because we'll be looking to the future to predict what healthcare might look like 20 or 30 years from now, the health system that many people in the class will depend on when they get into their 40s, 50s, 60s, and beyond. As a guys, I'm of one set of science fiction writers foresee the inevitable. And although problems and catastrophes are inevitable, solutions are not. So as well as discussing the problems that we face with healthcare, we'll also be discussing the solutions. The ideas that inform this panel are twofold. First, that healthcare was, is, and will continue to be the #1 priority of every government in Canada. Secondly, that boomers don't just occupy systems, they change them. Today we will put these two concepts together and discuss what changes will occur in the most important public policy priority in Canada. This discussion falls under our research theme, Health Systems and Governance. This is the second talk under this theme. Our first talk, offered by the Honourable David Dingwall, provided insights into just how difficult it was to bring about the changes in the Tobacco Act. He referred to lobbyists, special interests, politics, the inertia of institutions, public attitudes. And I suspect we will hear more about those things today. I would also be remiss if I did not point out that July 1st, 2018 will be the 50th anniversary of the implementation of the Medical Care Act, championed through the House by the late Honourable Alan MacEachen. The people who were in their mid-20s then are now in their mid-70s today. I wonder what their expectations were of healthcare and if those expectations were met. We have 4 very distinguished speakers to lead this discussion today. I'll introduce each of them just before they speak, and today we're going to start with Catherine Fielbeck. Catherine Fielbeck is the MacCulloch Professor of Political Science at Dalhousie University. She is cross-appointed with the Department of Community Medicine and Epidemiology and is a Senior Research Fellow at the Health Populations Institute. She is also a member of the MacEachen Institute Research Committee. Her research topics include healthcare governance, healthcare politics, human rights theory, and comparative health policy. Dr. Fielbeck's books include Healthcare in Canada, Canadian Healthcare Federalism, and Comparative Healthcare Federalism. Catherine, over to you.
All right, are the slides queued up here? Oh, look at that. Oh, okay, great. Well, good afternoon, everybody. So, as this is midterm week for at least some of you, I should say that I've been thinking about content in terms of pithy examination questions. So here's my starting point. And what I want to do is to introduce the discussion regarding the relationship between sustainability of healthcare and the aging of the population in a little bit more detail here. So let's start with this figure. Now, I know it looks like a Rorschach test, but it's actually the demographic progression of the Nova Scotia population. And as you can see here, even after a generation, the boomers are still with us. I mean, they're a little bit older, but they're still here. Now, I'm not sure I want to talk about the nature of healthcare, going into 2050, because that really does get into the realm of science fiction. But I think it's important to understand that this is not a problem that is going to die away anytime soon. So the big concern with the healthcare system, at least in this province, is really its sustainability. And one of the key challenges in that regard is population aging. Now, the first point that I want to make is that the demographic challenge, as you can see, is quite real. But I also want to emphasize that it's quite slow. So we may be approaching a demographic cliff, but we're not hurtling toward it in a locomotive. It's more like we're ambling toward it in a golf cart. So, for example, as you can see in this figure, the population aging only really accounts for about 1% of all the increases in healthcare expenditure in the country. Or if you want to put it a different way, healthcare expenditure isn't really increasing in lockstep with the rate of aging. And I think that Richard's got some really good insights on this issue. So I don't want to steal his thunder. I'm tempted, but I won't. But I do want to focus on 2 key propositions here. So The first point is that the population of Nova Scotia really is getting a lot older. I think that Nova Scotia and New Brunswick are duking it out, trying to decide who's actually got the oldest population. But both of them sit at around, I think, 18.5% of the population being 65 or over. So that's 18.5% compared to a province like Alberta, which is, can we guess? What's the population, the percentage of the population over 65 in Alberta? 11.5. So it's a considerable difference. So we are facing an interesting demographic. Now look at this figure. Here's the figure that has everybody, all the policy people, quite worried. So what this figure says is that not only is our population getting older, but older adults use up more healthcare resources, and the older you get, the more healthcare resources you use. So if you put those two propositions together, on the one hand, that an increasing proportion of the population is getting older, and you add on the observation that the older the population, the higher the cost, then you end up what the economist Robert Evans has crisply termed apocalyptic demography. And the problem here, I think, is really in the sense of determinism. Now, it is possible, we certainly may well experience demographic cataclysm in the same way that we may well experience a nuclear war with North Korea. It is possible, but hopefully, all things considered, it's not likely. So it is, to a large extent, the product of the political choices that we make, for better or for worse. Now, if you look at these propositions, A may be fairly rigid, at least within the confines of ethical policymaking, but B as a proposition of extrapolated truth is actually a lot more squishy here. There's a lot more room to play with. So the question for a lot of people is whether it is age per se which accounts for the higher cost of older adults or something else. And there's actually a whole lot of evidence to show that it is in fact something else. So I want to look at that something else in a little bit more detail. So one explanation for this is the healthy aging hypothesis. So this hypothesis says that we're aging a little bit more slowly than our parents because we're slightly more healthy. Or as one study argued, a 70-year-old German is projected to have the health status of a 67-year-old by the year 2025, and that of a 64-year-old by the year 2050. And in fact, to put this in a slightly more personal note, I play basketball every Sunday with a group of people, many of whom are in their mid to late 60s. Now, when I was a teenager, the idea of there being a room full of people in their late 60s who could actually and were willing to run was completely inconceivable. So these days, we do have people who do, in fact, like to run at that age. So things are changing, and they're changing in interesting ways. Another key variable that we have to think about is variable practice in end-of-life care. And the point here is that there's really a huge international diversity in approaches to interventions, especially in terms of cultural norms and medical practices. And one of the interesting things to note here is that where the practice is not to throw all of modern technology at every single person in decline, costs can actually go down as the population ages. And just to put this in context, approximately 11% of healthcare expenditure goes toward those in their last year of life. So, for example, the compression of morbidity thesis links these two concepts. So it argues that healthy adults can actually avoid poor health until fairly close to the end of their natural lifespan, at which point things happen fairly quickly if we let them. And for those of you in this room under 30, and there are a few of you here, I think it's also important to remember that it's not wise to lump all of those over 65 together in the same category. A lot of seniors are, in fact, quite healthy, even those that don't play basketball. And in fact, it's actually those with multiple morbidities at any age who require the vast outlay of healthcare dollars. And here's an interesting stat for you. In Nova Scotia, I believe it's the top 1% of healthcare users who use up about the top third, about 30% of healthcare expenditure, and the top 5% of healthcare users use up about 2/3 of healthcare expenditure. And these are largely on chronic conditions rather than acute ones. So, in sum, despite the demographics, it's important to stress that biology is not destiny. The demographic trends are, in fact, there, but I think that the real issues are political, and I've summarized some of them here. I think that some of our speakers will probably want to go into them in more depth. Bob Evans and others have, in fact, gone as far to argue that the costs of aging claim is a deliberate smokescreen used by those with skin in the game to justify financial expansion and to avoid evaluation and accountability. And they also have argued that this claim of the high inevitable costs of aging are used by those who, more scurrilously, want the public healthcare system to be unsustainable in order to justify the establishment of a private parallel healthcare system. Now, regardless of whether you buy that or not, the upside of all this is that the problem that we're facing here is not, in fact, inevitable. But the downside is that the real problems are, in fact, political. And politics, as some leaders of certain Western states are discovering, is actually quite hard. Thank you.
Thanks, Catherine. Richard Sayell is a Moncton-based economist and author. He's a former vice president of the University of Moncton and former director of the Donald Savoy Institute. Mr. Sayell has spent nearly 15 years working for the public service in a variety of departments, including the Privy Council Office, Industry Canada, and Transport Canada. He is the author of 4 books. His most recent, A Tale of Two Countries, How the Great Demographic Imbalance is Pulling Canada Apart, was a finalist for the National Business Book Award. Mr. Sayell.
Thank you very much. And thanks for inviting me. I do agree with Professor Fierbeck that the issue of healthcare is largely political in terms of the sustainability in Canada, and that demographics alone should not take down healthcare as we know it. But today I'd like to focus the attention of our, focus the discussion a bit on, not on population aging per se, which is a topic that many of us are familiar with, but on the highly uneven pace of aging across Canada. And that's something that we haven't paid as much attention to historically as we should have, particularly here in this region, because we are at the forefront of aging in Canada. The median Atlantic Canadian is about 45 years old, and it's going on 46, and if you go to the prairies, it's about 37. And Professor Fieldbeck's data is right. We're actually aging even a little faster than that. It's now 1 out of 5 in New Brunswick. It's official. That's a senior. And in Alberta, it's now about 1 out of 8. We'll talk about that briefly. I have about 7 or 8 slides. My argument here about A Tale of Two Countries is when I'm talking about pulling Canada apart, it's demographically. I'm not implying that the social safety net in Canada will be pulled apart. I'm just implying that there'll be challenges. Now, the demographic reality is here, and we're going to talk about it briefly. And the first consequence is that we think of demographics as gradual in nature. We only aging is a privilege. We only age if we stay alive, and it's one day at a time. But such a gradual process can have very dramatic and immediate consequences. And when it comes to economic growth, this is exactly what's happened. At the turn of the decade, the first baby boomer turned 65, and generally speaking, at least at the turn of the decade, it was about at 63 that people tended to retire in droves. And what we saw is that economic growth in Canada and in Atlantic Canada slowed down immediately, okay, because the number of people leaving the workforce was not replenished fully by those entering. So if you look at this chart, what you're going to see here is that before 2010, just before baby boomers started retiring, if you look at the blue bar, what you're going to see is that Atlantic Canada was growing at a pace that was roughly comparable with that of Canada. And if you look at GDP per capita, the red bar, which is an indicator of our prosperity, we were actually catching up with the rest of the country. So there was convergence, and Atlantic Canadians were getting closer to the national average in terms of prosperity. What we see afterwards is a complete change in dynamics. If you look at Atlantic Canada since, the blue bar with real GDP, economic growth has slowed down by about 75%. You know, we were at 2.1, we're now down to 0.5%. Now, some people will say that's a fluke, but you know, how many years do we need to make a trend? So this has been 6 years going, and that's the average. Sometimes we're doing better, sometimes we're doing not. But what's also interesting is that in the rest of the country, growth has not slowed down to the same extent. You know, we're in Canada, we're at 2.0, we were at 2.3 before. Why? Because there are more people coming into the workforce in Canada, predominantly because of immigration. Immigrants tend to settle, unfortunately, tend to settle in large urban areas and certain provinces in particular. And when we look at GDP per capita, the indicator of convergence, there's no longer any convergence. In fact, we are pulling apart economically, as the models predicted. So we are growing apart economically, and no one is forecasting any end to that. And obviously, anytime you try to predict the future 20 years down the road, it's true that it's science fiction. But at the same time, a lot of people are saying that when it comes to demographics and its impact on the economy, you should at least consider it. And some people say you should take it to the bank, but that's another story. Why is Atlantic Canada's economy slowing down considerably? Well, essentially because we're no longer adding people to the workforce. Actually, our workforce, it used to be the engine of our economic growth, and now it's the transmission is shifted into reverse gear. So you can see Atlantic Canada, the population, labor force growth going down. So this is a very crowded chart. I was talking about the aging process across Canada and how it's highly uneven. Well, we can see, I took the Statistics Canada baseline projection, and in 2038, for those in the back who can't see very well from that far, in 2038 it is projected that Atlantic Canada should have about 1/3 of its residents that will be seniors, and in the prairies it'll be about 1 in 5. So if you look at the welfare state in Canada, and you look at a region such as the prairies out west, it's still growing pretty strongly, it's pretty sure that part of the country will be able to maintain the status quo in the welfare state and the social safety net. You know, in 20 years from now, they won't have more seniors than we do have now, and they'll be, in my assessment, about 75% wealthier than they are right now, and they're already 50% wealthier than we are, okay? So large parts of this country will certainly be able to absorb the shock of demographic aging. They're slowing down, but not as meaningfully as we are, economically speaking. Now, I've looked at the projection for real GDP growth for provinces. Unfortunately, national institutes tend to not distinguish between among provinces in Atlantic Canada. They just lump us together and they say it's Atlantic Canada. But what we're seeing here is that there's a general agreement. I have some of my projections in there and some from TD Economics and the Canada Centre for the Study of Living Standards. And they essentially say that economic growth in Atlantic Canada will slow down considerably, much below Canada, and this is something that there's a general consensus about, unless technology saves the day or for some reason that we manage to do much better than we did in the past in immigration. Very much more, I'm talking about, you know, quadrupling your immigration levels at least without losing more immigrants than we are currently in order to get the kind of growth that we had before. We saw this chart earlier on, and it's true, this shouldn't be a welcome with fatalism. This is a reflection of current spending with current issues regarding end of life and the kind of spending that we're doing. It's not immutable, but that's what it is right now, okay? And what you see is that the numbers are higher as you go later in life because of it's cohorts of high mortality. Now, this is a status quo projection trying to estimate how much healthcare spending would occupy of our GDP, how much we would have to come up with if no changes are brought to the system, assuming a very reasonable rate of non-aging related costs. What we're seeing here is that in the prairies, in Ontario, and Manitoba, Quebec even to a certain extent, and British Columbia, they should be able to sustain the status quo. The kind of increases in taxation that will be needed to maintain the status quo, not even let alone finding efficiencies here, is about 3 to 4 percentage points of GDP. And in the past, the last 15 years, our fiscal burden has gone down by about 3 to 4 percentage points. So we can go back to where we were before if we have to. But in Atlantic Canada, it would imply a doubling of our spending on healthcare as a percentage of GDP. I'm not saying we should go there, and I think we should, find innovative ways to deliver healthcare services within the mainstream of publicly funded. But even if we didn't go there, 20% would imply an increase in our taxation burden of about 60 to 70% in Atlantic Canada. If we went there, a lot of people would vote with their feet, and it would accelerate the dynamics. So we were talking about cliffs earlier on. I'm not saying that this is the reality. I'm saying that this is where we're headed unless we change. Now, some people, and I'm almost done here with that chart, some people are saying that when it comes to non-aging healthcare, everything that's not related to aging, we will live within our means, and the parliamentary budget officer is assuming that these days. Last year, we were saying that no, we'll spend as we were doing before, but now provinces should be able to live within their means. What that means here is that if you look at non-aging, I've just parceled it out, and if you look at Atlantic Canada, aging is, we've slowed down. What I'm assuming here in the mid-range projection, in my book, I'm trying to say that this is the kind of spending that if you decided to remove the idea that you're going to spend more because GDP is growing faster. We looked at GDP and we said it won't be growing that fast. We'll absorb the shock. What it means essentially is for Atlantic Canada, we'll be absorbing just aging and nothing else. So the implication of that is, can we do that? Can we make sure that we take our spending down almost to zero in non-aging components of spending? And frankly, my view of that is probably not, because if you decide to let provinces spend based on their means, well, the prairie provinces who have greater needs, if you look at that, they will have increased their spending by 80% over the next 20 years or so, and we won't have increased our spending at all almost. And when we have to think about providing healthcare services in the future, well, we have a unified or a single market for health professionals outside Quebec. So we're going to have to be competing for resources. And whether we like it or not, I don't think that 10% increase in spending over 20 years will pay for healthcare services, if we have to compete with other provinces to secure the health professionals when we know that we're aging faster than the rest of the country. And also with that kind of money, you'd have to pay for technological development. Some people say that technology will lead to lower costs in the future, but in the past it's always led to greater costs. So we'll have to see. No one knows at this point. But what I'm saying is that I don't think we can have an environment where people are just going to live within their means, and that's going to be fine, and doctors here will not ask for more money, even if people in Alberta are paid twice as much. Okay, that's kind of the assumption, so I'm not entirely sure of that one. But just to show that there are debates about our ability to absorb additional costs in the future. So I'll conclude. Here, essentially, my argument is to say that in Atlantic Canada, we're going to need more help. People don't like to go to Ottawa and ask for more money. But I think that down the road, unless we manage to perform miracles in terms of redistributing, in terms of growing our economy and taking down our healthcare spending, we're going to have to get more money from Ottawa. And what's the mood in Ottawa these days? Well, Ottawa has now become more redistributive over time. Over the past 15 years, it's become less important in terms of taxing Canadians, and it's become less redistributive. The CHT, the Canada Health Transfer, the CST, the Canada Social Transfer, is now distributed on a per capita basis. In the past, it used to take into account the fact that we were poor provinces. Not anymore. The CHT has been taken down from 6% to 3%, a floor of 3%, with a floor of 3%, sorry. Equalization has been capped. And when we look at federal transfers, we love to say that, hey, transfers are, it's per capita, it's fairness, it's equity. Well, let's see if it's fair. The per capita formula has led Alberta to get about 12% increase annually in their CHT because they're young, because they're growing faster in terms of demographically. But they're younger and aging slower, but they're getting 3 times as much as we are because we're not growing as fast. So is Ottawa in the mood to provide more funding? I don't know. But down the road, I believe that if we are to maintain a single healthcare system in this country, that Ottawa will have to acknowledge that demographic reality. So thank you very much.
Thank you, Richard. Peter Vaughan is a Johns Hopkins University-trained physician executive and is a chair of the board of directors at Canada Health Infoway. Until this past winter, Dr. Vaughan was Deputy Minister of Health and Wellness in the province of Nova Scotia. Before becoming Deputy Minister, Dr. Vaughan was the CEO of South Shore District Health Authority, CEO of the Canadian Medical Association, and President of WebMD Canada. He's an adjunct professor with the Faculty of Computer Science and Faculty of Health at Dalhousie University.
Thank you, Kevin. Thank you. I'm just supposed to move this over. Wow, that's great. Great to be here. Thank you for inviting me to be part of this August panel. And I want to say that the first two speakers really did a great job laying the foundation for what I'm going to talk about. And I'm going to really talk about the post-baby boomer world, because I think that's what we're really, you should be interested in. And some of the themes that we've heard will be picked up. But I think it's important for us to realize, those of us who've tried to make big system changes, that it is very, very difficult. The status quo, the pull of the status quo, I always used to remind staff, is like the pull of gravity. It takes a lot of focused energy to be able to release yourself from that. Because there are so many people who have vested interests in the status quo and what the current state is, as has been described, than those who can imagine a different future and those who are interested in a different future. And I'm hoping that many of you in this room will be interested in creating that different future, and that's what I'm going to talk about today. But the reason it's so hard, as Machiavelli reminds us, is because the interests of the status quo are so strong because people will adhere to their survivability of the present with the passion of partisans. And we want to come back to that. We've heard a lot about money. And I think it's important for us also to recognize that governments want to see healthcare successful and are constantly looking for value for money. I spent a lot of my effort, I'd say a good significant portion of my effort as Deputy Minister of Health and Wellness in Nova Scotia, containing cost, making sure that the bottom line was able to fit in to the larger provincial budget, which has other things to do. So I think it's important for us to look at the context. It's also important for us to appreciate that it's been replicated numerous times. At least 30% of what we do in healthcare has absolutely no value. I want you to remember that, okay? So more money isn't the answer. It's about getting smarter. It's about being more efficient. It's about actually looking at what works and what doesn't work, and we'll come to that. It's also important to recognize that medical error is the third leading cause of death. The third leading cause of death. So just doing the status quo stuff isn't not only expensive, it's also bad for our health. And there's lots of evidence and research around that. At least 50%, maybe two-thirds of what we spend in healthcare in this province is on the 5%. And I love that figure, because when we're talking about roughly 50,000 people, for the sake of argument, and we're spending over $2 billion for 50,000 people, that is a great big red warning sign that there are better ways to be doing things than what we're currently doing now. Just the status quo isn't going to work. I also want to remind us, and I'm sure Gaynor Watson-Cree is going to remind us again, that the healthcare system only attributes to 20% of our health. Okay, the sickness business, or what I call the fix-it-shop business, only actually contributes to 20% of our health, but we spend 41% of our entire budget on that. And 70% is other things, jobs, behaviors, those kinds of things. So I don't want to lose sight of that. We got to talk about special interests, and it's important because this just came out in the BMJ last week. If you missed it, that most new oncology drugs come onto the market without clear evidence they improve quality or quantity of life. And yet, as Deputy Minister, constantly we're lobbied by interest groups, and the pharmaceutical companies are expert at putting people out in front of this to tell you stories that actually doesn't work. So that's an important component of the affordability question that we're talking about. It's not just about money. It's about, does it work? Physicians love, I'm a physician, love to talk about this. I started physician resource planning with Jonathan Lomas in 1978. It's a long time ago. And I think it's phenomenal that we're still talking about physicians in isolation from nurse practitioners and social workers and nurses and all the other, the collaborative team that is the cockpit of healthcare today, let alone the future. But the point of this slide is that we've been growing physicians 3 times the rate of population growth. And why do we have trouble getting physicians? I ask you that question and leave it there. This is the black hole of healthcare. right? This is what Treasury Board colleagues talk, the black sucking hole of healthcare. But I love this slide, not because of the black sucking hole of healthcare, but because it's a great metaphor for our change in our worldview. And if anyone's reading the paper today talking about gravitational waves and the implications of that, it changes our thinking. You know, I love black holes because the event horizon of a black hole is where our understanding of the known universe breaks down. Quantum mechanics and classical physics do not explain the phenomena of a black hole. So this is where we are in healthcare. We are shifting from a post-medieval provider-centric hierarchy to a democratization of healthcare. And I love this, because now we're going to shift into the future a little bit. This is, by the way, the present. This is a company called Babylon in the UK. And they will handpick the doctor for you, right? Okay, this is a real Weltanschauung worldview shift for you here, because they've picked the doctors. Only 1 in 100 is good enough for you if you are part of their process. And they go through all the quality and efficiency processes, and it costs you, this is the Netflix of healthcare. By the way, this is not the future, it's here today. £5 a month. It's about the same as a Netflix subscription. And the reason that is because that's the way the world is going. There are many parts of the world people are paid on a daily basis on their cell phone. And so how does it fit into my affordability of what I want? And it gets you instant access with algorithms in terms of screening to make sure it's appropriate for what you're getting, and they will e-prescribe you something if it's necessary. So you get video conferencing, or you get texting, 24 hours a day, 7 days a week for the price of a Netflix subscription. That's today. I was privileged enough to, 2 weeks ago, I was speaking in St. Louis at the big 5 HMOs, Intermountain, Mercy, Mayo, Kaiser Permanente, and Geisinger down in St. Louis. And we were at the Mercy Virtual Hospital. This isn't something fictional. This hospital has been in existence for 9 years, has no patients, not one, but treats over 400. Has doctors and nurses, but no patients. All patients are treated remotely. Over 400 around the United States, some around the world, including ICU patients. They have reduced costs by 40%. They've reduced what's called being readmitted by 40%. They've reduced 50% mortality by sepsis. And sepsis is one of those sneaky things that people have trouble diagnosing it. Somebody comes in with a fever, they're not really sure, they can't find it, atypical. They use AI to screen people and alert before the clinicians have any idea that there is any indication, unless you're really sort of Doogie Howser or somebody. But the point is that medicine is so complicated that the AI is an assistive tool. It doesn't replace doctors and nurses. It's an assistive tool. People are able to stay at home. People are able to be better. They're able to reduce some of those complications of being in hospital, which are serious, by the way. We call them iatrogenic. This is real. This isn't the future. Both of these things I'm talking about are today. These are things that you're going to want, and these are things that we need today. And I love Amelia, because Amelia is AI in real time, and she can be in whatever cultural sensitive, image you'd like to see, whatever is appropriate for you. And she's currently used in the service sector, and she can, in real time, understand your emotions and adjust and react to your emotions. That's today. This is not tomorrow. This is not 5 years from now. This is AI in action. You start to combine these opportunities of Amelia and Babylon and virtual hospitals, and you start to see in your own mind a picture of the future that is actually happening. And I want to remind us, it took 150 years for vitamin C to be taken up in the British Navy after a good case control study, because it takes time. It's not just the new ideas, it's the diffusion over time in a social network. It's all about data. My watch, thank you, my watch beams up my heart rate of my consent, and millions of people around the world are doing the same thing. They have been able to detect atrial fibrillation before it becomes clinically apparent. Imagine the possibilities of prevention, of hospitalization, and all its the quality of stroke if we could do that. I think we have an opportunity in this country and in this province, in this region, to start to lead the way, because necessity is the mother of invention. It's not about maintaining the status quo. It's about creating a real-time health ecosystem, and that I think that's marketable worldwide. I think it's a failure of imagination. A failure of imagination that the 9/11 Commission said was the primary factor in those unfortunate circumstances. If we don't think about what the future might look like differently, then that's on us. We also have to think about what the negative consequences are. We have to think about the challenges. We have to think about what are the legislation that we need. Europe is further ahead on digital human rights in terms of access to high-speed internet, in terms of regulation, in terms of who has access to my data. So I want to say thank you very much. I hope we have a good discussion.
Thanks, Peter. Dr. Gaynor Watson-Creed is a dedicated leader and is passionate advocate for the role of public health and what it can play in advancing health equity. She's the acting Deputy Chief Medical Officer of Health for the province of Nova Scotia and served on the One Nova Scotia Coalition. In 2013, she was awarded the annual Public Health Champion Award from the Public Health Association of Nova Scotia. Dr. Gaynor Watson-Creed.
Okay, so good afternoon, everybody, and it is my pleasure to be here with this esteemed panel, which I have to say was giving me the worries up until Dr. Vaughan made his comments about the relatively limited impact of health system spending on the trajectory of health. For a while, I thought we might not go there, and I was thinking, here we go again. The public health physician comes last as the heretic on the panel who's going to talk about all things that are not related to healthcare spending. Because that, in fact, is my training. That is my area of expertise as a public health and preventive medicine specialist physician, is in prevention. And so I do get a little bit alarmed when I hear ongoing conversations about the current and future state of health systems that only focus on that spending, because I wonder why we're not spending more attention or putting more attention on the possibility of actually intervening now to prevent that future from becoming a reality. As Dr. Vaughan pointed out, the interventions are not likely to be in the healthcare system. So the number that he quoted actually comes from a number of places, including the Senate report on population health that was produced in Canada in 2009. And the estimate was actually between 13 and 25% of your health will come from government's investment in healthcare spending. It doesn't actually matter how big the investment gets. The limit to how that will impact your health is still going to be at a maximum 25% of your health. That's because the other systems of influence that will more heavily impact on your health are way outside of healthcare systems. They are in systems of education, so having a grade 12 graduation, math and literacy-based education is actually key. We believe that that contributes up to 50% of your health outcome. It is the setup for good health. It comes from your environment, particularly your built urban environment. So to the extent that we can reduce sedentary behaviors, for example, by replacing them with active behaviors, we believe that contributes somewhere between 30 and 40% to your overall health. So you start to see that health systems in and of themselves are not necessarily the focus. They are one of 11, depending on who you read, 13, 15 determinants of health. Not all of those determinants are modifiable, I would say, as a physician. And that's language that we use in medicine a lot. So we talk about what are the risk factors you might have for ill health that are modifiable versus not modifiable. Aging has often been put in the category of non-modifiable risk factor. So we age. We can't do anything about that, so you kind of have to cope. And we put in place the systems that will hopefully help you age well. But how do we prevent poor aging is often not part of the conversation. And yet, there is good data from around the world that suggests that the interventions that we need to prevent poor health outcomes actually don't have to take that long to see the result. So there's a WHO report, which if you haven't seen it, I highly recommend. It's the WHO Case for Investing in Public Health from 2014. And they actually state that many of those interventions around chronic diseases, even when started late in life, we can start to see the return on that investment within 1 to 2 years, We often quote in public health 20 to 25 years, which drives policymakers bananas. But in actuality, the study from the WHO, which looked at 25 European nations, and their investments in public health over time, was actually able to show a return on most chronic disease interventions within 1 to 2 years. They actually have produced a handbook that is for third world nations that states, here are some low-cost interventions, less than $1 per capita, that you could use to prevent these outcomes. And I start to wonder, as an Atlantic Canadian, we often refer to ourselves as a developing nation. I wonder if now's the time to start investing in WHO technology, because it's accessible and it's attainable. So my orientation is around that. And the way we frame it in public health is something like this, and some of you may have heard me talk about this before. So in medicine, we talk often about what's known as levels of prevention. So we talk about primary prevention, which is there's a risk factor for disease out there. We should be doing everything we can to prevent that risk factor from becoming actual disease in an individual. That's largely what the primary health care system is here to do. That is what family physicians do, and often nurse practitioners on a day-to-day basis. Secondary prevention is too late. The disease has already started, but if we catch it early, we can create the conditions to prevent the worst outcomes. We might even be able to reverse the impact of the risk factor itself. And then tertiary prevention is too late again. The disease is now established, but we'll do everything we can to make sure that it's managed well. The work of public health systems is known as primordial prevention. And if you have not heard of that, I'm going to explain it to you now. Primordial prevention is where there were risk factors for disease to occur, what if we could actually prevent those risk factors from ever existing? So primary prevention is the risk factor is here, make sure it doesn't become disease. Public health is how do you prevent the risk factors from ever existing? But here's the thing. Primary prevention, secondary prevention, tertiary prevention currently get in this province over 40% of provincial government spending. Public health investment in this province is hovering around 1.5%. The national and international recommendation around public health spending is about 5% of healthcare spending. We are at about 1.2. So when you start to see the potential of prevention, I often have audiences go, oh my God, why are we not doing more of that? And I go, I don't know. I don't know. But there is certainly potential there that again is borne out by the literature. I point this out because the framing of this conversation has been around how do we sort of deal with the impact that will be left behind by boomers as they go through the system and change it. But I'm aware of, I think, a phenomenon that boomers also bring, and I would say that Gen Xers and millennials bring as well, which is not only do they change systems just by virtue of passively going through it, they also seek to change those systems for the better. And I think all three of those generations have demonstrated that potential. And so, I think it's helpful to put some of this prevention dialogue into the discourse for the purposes of creating the opportunity for rich policy dialogues that might actually get us into that space. Certainly as part of the One Nova Scotia Coalition, we spoke to many boomers who were very clear that the description of the aging boomer who was slowly getting more and more hunched and more disabled by their chronic diseases was not one that they aspired to. And that many of them were able to describe not only are they able to age well, but they're also interested in being ongoingly productive, including economically productive, in our province, which again creates another sort of economic boon and imperative for us. So I think there's all kinds of opportunity there. With respect to my question about why are we not talking more about prevention, I guess there are probably a few things that I could point to. I think the rhetoric around that for many years from public health practitioners like myself has been that the returns that we will see from those investments will be 15, 20, 25 years, which does drive policymakers bananas, and they just tune out. There is that. I think there is something else, which is when we are the purveyors of the conversation, we are often seen as self-interested, which is kind of a strange thing, because if we were actually succeeding, we would probably put ourselves out of work. But we are seen as self-interested, and so there's a sort of a deaf ear that gets turned to that conversation over time from that respect as well. I do wonder about this notion of what's known in public health policy circles as the prevention paradox, which is that once you have prevented something from occurring, people can't see that it would have been there if you hadn't been there to prevent it. And so it becomes this very crazy cyclical place that you end up in where nobody can see the prevention because you've already prevented it, and so nobody can see the prevention is important. And so the prevention paradox actually is very real in public health policy circles, and certainly does hinder our capacity to have these conversations. And yet, I only have to look as far as interventions in tobacco, which, yes, we're driven by health systems, but we're also driven by other systems, including business interests, sort of counter to tobacco interests that would have played out there. I look at some of the major investments or major advances that we've had in communicable disease even actually never came from vaccines or medical intervention. They actually came from intervention by systems of planning and engineering. And so I think those are some of the dialogues that we are failing to look at when we look at health system spending as the issue. And by continuing to focus on health system spending, I worry that we create sort of this self-perpetuating cycle, which is we're going to talk about health system spending and focus on that as a problem when in fact the solutions are probably far beyond that. So coming at the end of the panel, I deliberately sort of set myself up to be open to what I heard, and I think by the space that my colleagues have given me to talk about prevention, I'm assuming that they did that deliberately because they knew that's where I would go. This is kind of the synthesis that certainly I'm ending with, is that there's a missing piece in this policy dialogue about health system spending, which is on prevention. I think that's it for me.
Okay, thank you so much. We've asked 5 students to prepare questions for our panelists, so we'll get to those 5 questions first, and then we'll open up the floor for additional questions. So I'll just remind those who are asking questions to wait for the microphone. Katie's working around with the microphone now, and also if you can just state who you are in the program that you're from, if you are in a program where you have some sort of affiliation. And we'll start with Terry Ajadi with the first question.
Hello. Thank you so much for an excellent panel session. My name's Tari Ajadi. I'm a master's student in political science, and my focus is on health equity and public policy, so this is a very interesting and engaging topic. I'd like to address my question to Dr. Vaughan. You mentioned at the end of your talk that data would be the platform for the necessary paradigm shift that we will need in healthcare. And I'd agree that data is important, but I'm interested in the political will in Nova Scotia for a wide-scale kind of longitudinal approach to data for better public health outcomes as well as better outcomes in the healthcare system. I know that Nova Scotia's made some forays into big data with the Nova Scotia Health Atlas, for instance, but I'm unsure as to how committed the provincial government is to this idea. Could you speak to what steps the provincial government needs to take to create the kinds of data collection necessary to support such a transformational shift?
So thank you for the question, and it's a great question. I can't speak for the government of Nova Scotia. I'm very clear about that. I think that Nova Scotia is seen, outside of Nova Scotia perhaps, as a leader, because Nova Scotia has the foundational pieces. You can't put up a house in one day. You have to lay the foundation, you have to put the structure, electricity, the plumbing in. I think Nova Scotia is doing that and has done the right thing in terms of laying the foundation. In terms of the steps to do that, I think there's a lot of interest, and I think what I'm alluding to is really how do we create that health cloud? Because I think that's where the data is. And there's a lot of conversations around that taking place in Nova Scotia. I'm speaking at the BioNova conference tomorrow. So I think there's a lot of people who are interested in saying, what can we do? What are the elements that we have to do? And that puts us in a really good position, because it's the data that it really allows us to understand, like my analogy around atrial fibrillation, things we haven't imagined. We have that ability and that need for all the things we've heard about to be able to do things differently. So I think it's not just Nova Scotia, but I think it's Nova Scotia working with its Atlantic partners in particular, because then we're talking 2.5 million people, and we start to get a little bit of scale. It's maybe a petri dish in terms of data, but it's a great platform for that. So I think there are a lot of good things happening in Nova Scotia to do that.
Marcus Brower.
Good afternoon, and thank you very much for your presentations this morning. My name is Marcus Brower. I'm a Master of Public Administration and Master Library Information candidate here at Dalhousie. This question is for Dr. Vaughan. We know that the Canada Health Act has largely become irrelevant today, and the federal and provincial governments are unable to agree on the details of their transfer payments or remedies that impact on the aging demographic, which is forming the perfect storm for the Nova Scotia Health Authority. Canada will require thousands of more long-term beds, and many of these beds are blocked by the aged, many of whom want to return to their homes. Aside from the technology that we've discussed during your presentation, what are some of the other efforts that are being done to maximize the use of home care to minimize the bed blockers?
Well, I think first of all, it's a great question. Home care clearly, I think, where more effort needs to be put. There's a lot of reasons why it's challenging and difficult to stop doing one thing to do another, and I think that's where all of us would probably agree that it's challenging to do that. I think in home care, we're seeing some really good opportunities, and Nova Scotia has been a leader in this again. Not known to most Nova Scotians probably, in terms of paramedicine, working with nurses, nurse practitioners, and others as a part of a team. In palliative care, for example, Nova Scotia is a leader in paramedicine in this regard. So I think there has been real concrete specific things that Nova Scotia has been doing to make home care within the framework of our current model more usable to individuals. Can we do more? Absolutely. For some of the things I've been talking about here today, there's great opportunities to partner with different components of the sector, and internationally there's some large players. I think if we have to make this comment though, it's very important for us, and we haven't really understood it well in this conversation today, that many of the players in the healthcare home care space have nothing to do with traditional home care. And I'm alluding to Amazon and Google and Apple, who are very much moving into that space very, very, very quickly. So, there are lots of questions, lots of things we need to imagine around the implications of that, but I don't want to lose sight of that. So we're doing a lot of things within a structural system that's there, but there's a whole lot of stuff going on in parallel that is focused on home care.
I'm inclined to ask if Dr. Watson-Creed wants to contribute to that question about home care and the role for public health. Any thoughts on that?
Yes,
we tend to think about it in terms of earlier in people's lives, but what about later in people's lives?
I was sort of thinking more along the lines of sort of the connection between that question actually and the previous question on health equity, because even when you look at sort of home care users from a health equity perspective, I would wonder how much understanding we have of who actually is most heavily impacted by that issue and why, for the purposes of informing that dialogue around how do we prevent these types of outcomes with home care and with long-term care beds. So, I'm a little worried that our knee-jerk reaction, I think in part because of the pressures that Dr. Vaughan has mentioned, which are, all of those other competing priorities in healthcare, such that we're only giving a little bit of our attention, a little bit of our brain power to the question, for example, around long-term care facility beds. I would wonder if that wouldn't be better served by a broader exploration of, so who exactly is the demographic that's most heavily impacted here, why, and how do we actually get ahead of that in a way that we don't have to worry about those impacts anymore? That is actually a data question. That's a health equity data question. That is data that we have imagined, we just haven't executed.
Brianna Cochran.
My name is Brianna. I'm an MK student. My question's also for Mr. Vaughan. You brought forth many innovative ideas for the future of the healthcare framework. However, there are still a lot of people who are skeptical of technology. For example, the idea that eventually we will replace people with technology. How do you plan to convince Nova Scotians, especially in rural areas, that these advanced technologies are indeed favorable and worth investing in, rather than investing in other areas of healthcare that seem more urgent right now?
Thank you, Brianna, for that excellent question. I think some of it is around you don't know what you don't know, and as I said, the pull of the status quo. So you think everything looks like a doctor, then it's all about a doctor, it's all about hospitals. But in the rest of our world, I think we've seen that mobile technology, for example, and I'm not about technology. It's about people, but getting the right evidence-based treatment to people. I think there's a whole lot of evidence around what goes on versus what is appropriate. And just talking about it doesn't change it. So I think if people can see it, like if you could see the virtual hospital that I have seen, then you would go, well, why don't we have one of those? And that's what I'm trying to inspire in you. And it's similar with the Babylon, 1 in 100 doctors is approved. It's not just any warm body, just get some doctors, but it's about what are the best people we can get, that you can get access or your grandmother can get access wherever he or she may be. So I think it's about people seeing these things. And frankly, it goes back to the diffusion of innovation and the adoption curve, So I think, you have the innovators, you have your early adopters, you have the early majority. Until you have them, you don't reach a tipping point. But I think Nova Scotia is a great opportunity because of all the things we've talked about to be that place where you can show and showcase that you actually get better results and focus more resources on the kinds of things that prevention really deserves than what we're currently doing now, because that train is not going to yield better results. And again, third leading cause of death is medical error.
I might just insert myself for a moment, if I may, by asking Richard a question about the role of the federal government in the future of healthcare. So we've just come through this period of renegotiating a funding formula transfer to the provinces, and I don't think the provinces got as much as they had hoped, and the federal government seemed to kind of play a divide and conquer sort of strategy. And I had heard months before this from some folks from Ottawa that this was going to happen because the provinces didn't do enough with the allocation they received, whatever, a decade earlier under Paul Martin. And as a result, they set themselves up that they weren't, because there weren't enough incentives for them to save money. I wonder if you might comment on this.
Well, it takes us into the comment that Dr. Watson made regarding, Vaughan. So Dr. Vaughan said regarding the provider-centric aspect of healthcare in Canada. When Paul Martin announced the Fix for a Generation, he announced that healthcare funding, federal health transfer, would grow by 6% annually for 10 years. Well, what happened is that you saw wage inflation that was almost 6% for 10 years. And it makes sense, because if you tell people in the system that there's going to be 6% annually more available to you, and that you can hold the system hostage simply by saying, well, if there is money in the system, we need catch up, and so it was the great gravy train passing. I'm sorry to say it that way, but look at the data, that's what's happened. So the key here is, what role can Ottawa do to incent change structurally? Knowing that the world that Mr. Vaughan describes is one where you have innovation enabled through a multiplicity of actors providing services. Here we have a state-centric system that is extremely averse to change. There's a joke made about the public service saying that if it fielded a hockey team, it would have 6 goaltenders. Okay, so why? Because it's the wheel that whatever squeaks most will get the grease. So in a system such as this one, it becomes an inherently political issue. So for political scientists out there, there's a lot of stuff to be looking at. Path dependency. Why is it that we keep on wanting change but do not get it in exchange? And one last comment that I'll do about that is the role of technology. The power of technology in the years ahead. One of the reasons why my forecast, I'm really concerned about putting numbers, it's not a forecast. The status quo projection, putting numbers such as those out there, is that we have no clue what the healthcare system will look like in 20 years from now. But we can look at what's happened over the past 20 or 30 years. And we've been on the cusp technologically for quite a while, if you listen to techno-optimists. They were saying, we're on the cusp, it's going to change. 10 years from now, you won't recognize the system. But what we saw is that, yes, we have now the ability for radiologists to have x-rays read in India or artificial intelligence to diagnose stuff. But we didn't change the fee compensation in exchange. So some people now are making 3-4 times more money, not working more, actually working from home and looking at this stuff from a computer and not really talking to patients. So how do we get to Mr. Vaughn's world, knowing that we live in an inherently political world?
Catherine's going to tell us. I'm wondering if you have a comment about the politics of the healthcare decision in the fall about being. Just they were so tight-fisted after being so generous, and then a new Liberal government comes in, and their first big decision was we're rolling this back from 6 to 3%. Were you surprised by the politics of this, or how did you interpret the politics?
No, I think that Richard's absolutely right, and I think that the provinces had a history of taking advantage of the money and essentially using it, spending the money on the loudest voices rather than to achieve change. And I think that any federal government would have done the same thing, knowing that there's no point sending good money after bad. But I think that the most interesting point is sort of an amalgam of both Peter and Richard, insofar as we really do need a lot of IT change. But the problem is that we have such segregated provincial systems that I'm very skeptical that we can actually achieve change without the money needed to achieve change. So you have a province like Nova Scotia that could benefit considerably from a lot of IT change, but at the same time, we are so focused as a province on just fighting fires and trying to deal with what's on the table that to be able to, sit back and think about what's happening in the future is a luxury that we can't afford. So I really appreciate Richard's point that, what we really need is the input of Ottawa in such a way that we are allowed to achieve a form of structural change that is based upon IT systems. And that, unless we have that, we can't think about some of the useful changes down the road that we could be able to take advantage of. Some provinces may. I think that Nova Scotia will be left behind more and more under the current regime.
Comments from the other side of the table on this, from the practitioner side?
The project that came to mind for me as you were talking, Catherine, just as an example, is the Panorama project for public health, which if folks are not aware of that, was launched about 13 years ago with the promise of being sort of the federal IT solution for, in particular, public health, communicable disease management was kind of the big focus. I think the challenge that we rapidly ran into, that I think we're finding ways around, was that the independence of the provinces was such that individual provinces could look at what was meant to be a pan-Canadian solution and go, yeah, well, that's not really going to work here for whatever political or other reasons, and so they could opt out. And so the project got modified based on those opt-outs by individual provinces without having a global look at how all that opting out and modification might impact the whole project. And so now you have a province like Nova Scotia who's heavily interested in this product, but it's not the same product that was launched 13 years ago. And there's no sort of recourse where all the other provinces in many ways have moved on. There's no recourse really for Nova Scotia to sort of come back to a place of, so what would have made the most biggest sense for this and us in our national context, which is where we started, sort of our playing in that realm. And so, I'm just thinking about the question that was, that I think your comment started with, the Canada Health Act may not be as relevant as it previously was. And I think, some of what frustrates our health system conversations is that if the Canada Health Act has teeth around that, we're not seeing those teeth come out when we, when we need them.
Can I make another point about data? I have to say, I've got an Apple Watch, so I'm not totally a Luddite, but I am fairly skeptical about some of the data. And part of this is driven by the fact that for the longest time, Twitter was trying to get me to follow Justin Bieber, and I have absolutely no idea why. And if that's the state of algorithms, then I'm kind of worried. But I do think that where we are going technology, you can have a very utopian but also very dystopian in terms of thinking about science fiction. And one thing I worry about is the extent to which technology is going to lead to a different kind of two-tier system in which essentially the less well-off are being treated by robots and apps, and only the very rich can get real doctors. So those kinds of things have to be, the wider socio-political context also has to be figured into the discussion here as well.
I wondered if the robots wouldn't actually be better. Peter, any comments on that? I mean, that might be the privileged access. It's who has the credit card to swipe and get access to the best robot. But,
I guess I want to step back just to the original sort of
Please.
questions. I was at the table during the most recent rounds of negotiations on healthcare from the very beginning to the very end. And I think from the province's perspective, there's a concern that the federal government puts money onto the table and then walks away. And let's not forget, the federal government used to contribute 50% of every dollar. And they backed away and backed away and backed away. So the provinces don't forget that. So they're very leery of, your great ideas and, here's a bit of money for a few years and then we have to carry the can. That was the crux of a lot of the acrimony in the room with the provinces and the federal government. On the other hand, I think the federal government wanted to see a measurable return on investment, wanted to see outcome data on whatever dollars they put on the table. And I could understand that, and I agree with that for all the reasons we've talked about. So I think the federal government today is very interested in targeting money where there's going to be impact. And so it's not just about 6%. They were trying to get it back to for their own reasons, for their own budgetary reasons, 3%. But focused all of that money on evidence of measurable outcomes. So that became, I think, a very touchy point for the provinces and territories. In terms of technology, it's not going away. And that's one of the reasons I think we have to have this conversation, is that the Netflix of healthcare is going to be there. And what do we think of that? First of all, do we know it's there? And so then we have to think about, well, if I can access that and I've got $9 and a month and I want to do that, should I be able to or not? So these opens up, I think, all kinds of very important questions, as well as the fundamental questions the Europeans are asking around access to the internet as a basic human right. What about me? What are you storing about me? The data elements about me. But what really gets me is not that, which I think it's the Amazon owning that data, which is why I'm such a strong proponent of a publicly funded health cloud in Canada. I think it's a great opportunity for Canada globally. But I think if we don't, then our data is going to be used by Amazon and Google and Apple, as much as we might love those technologies. That's a problem, I think, from a publicly funded healthcare system, and it's particularly a problem because we need to understand that technology is changing so fast. Let me just give you one little example. You can store text in DNA today, right? The entire works of Shakespeare are stored in E. coli, and a comedian can make a lot of fun about that, but it's great shit, man. But anyway, they can store video in DNA. So the notion of VR and AR and all those cool things, that's so retro, man. It's so retro because, everything is getting much faster, and the ability to change the biology and technology faster than our comprehension of the implications. And my plea is that we start to have that conversation.
I'm really worried that Amanda Bradshaw is sitting with, and we're using up all of her questions. Where is Amanda?
Can I borrow just 5 seconds of the time?
Oh, headline only.
Okay.
Headline
Well,
only.
technology amplifies opportunities, and healthcare is a luxury good, meaning that as you become wealthier, you spend more on it. So think about where these technologies can lead you in terms of, they talk about designer drugs and the ability to cure various types of cancers. And remember that the older we get, the greater the incidence of cancer. So it's not only a source of possibility in the sense of, how can we find savings, but it's also a source of future spending that is going to be hard to deprive to those who have less. There's an equity issue here. So it goes both ways with regards to technology.
If you were a journalist, the Sun would never hire you if you produced a headline like that. You'll never get hired by the Sun. Amanda Bradshaw. No, she's... Oh. Okay, go ahead.
So my name's Amanda Bradshaw. I'm a first-year student in the Masters of Public Administration program at Dal. And thank you guys for not only for the presentations, which were great, but for the opportunity to engage in discussion like this. Is really helpful and really cool to see everybody talking from their own perspectives about these issues. So my question for you is about the implementation. It's for Dr. Vaughn, sorry, as well. But I think Dr. Watson-Creed could probably comment on this as well. It's about implementing competency-based value systems and planning ways to ease the burden on healthcare service providers. So substituting service providers with alternative providers who have the competencies but not necessarily the credentials that are normally required to provide such services. So this was discussed in your paper in 2007, A Healthy Society, and I think we've seen some examples of this just within the integration in the healthcare system in Nova Scotia and initiatives like the community health teams and mental health peer support, et cetera. But what are some of these special considerations that must be made to control for risk when we are utilizing this system?
So thank you, Amanda, for that question. I think, first of all, thank you for reading my paper. That's two of us. So, first of all, competency as a requirement across all health professions was mandated, 15 years ago by the premiers on the Agreement on Internal Trade. So there's been a lot of resistance by the professional associations, and I don't know, if you've read Elliot Krauss's book, The Death of the Guilds, but you start to see, the elements of the guilds are still very much active in the status quo structures of the professions, very much so. So I think there's a lot of resistance to that. They are starting to move more to competency-based assessment. It's really hard to do that work, to be fair to them. It's not an easy thing. It's much easier to be credentialed. Show me the piece of paper you got from university and I'll give you a license. It's much harder to do a competency-based assessment. I think as we move more into the world we live in of large data, then it's easier to be able to evaluate individuals, and I can see this in some places in the world that are doing this already. Many of the HMOs in the US, the NHS in the UK and other places are starting to use that data and the outcome data to evaluate clinicians and not just doctors. So I think there's, that opportunity exists today. It's about focus and how we decide what our priorities are. But I'll stop there so others can have an input.
Did you want to add to it?
Yeah, I'm just thinking about the part of your question that's about the controlling for risk, because I think certainly, and I do not pretend to speak for most physicians because my practice is so different than most physicians. I'm in a fully multidisciplinary environment that when I was the medical officer of health, for example, for the Halifax area, included 110 different health professionals and non-health professionals as well. And that makes sense for public health because what we are dealing with is communities in their community context. And there's a whole variety of things that need to go onto that are way beyond, quite frankly, what our credentials can provide. So I think there's a minimum set of credentialing that needs to be in place maybe for the risk management issues that you've created, which are not insignificant. And I think in many branches of medicine, that's true. It's no less true in public health. So for example, what I always say to people about my training in, for example, outbreak management is, when the tool that you have is the dispositions, for example, in the Health Protection Act, which is the big legislation that says public health can do crazy things like quarantine people and put them in isolation, you probably want somebody to practice that under supervision several times before you let them loose on the public, right? Because that would be really bad. So I think there's a minimum set of sort of risk management that you do need to put in place. I also think, though, that there's a lot of room for the tacit knowledge that communities have that isn't couched in a credential that is very helpful to building healthy societies. Just as a small example, this came up when we were discussing actually Chapter 1 of the One Nova Scotia Coalition report, which is all about the early years. And I had a conversation with many of the experts, public health experts and pediatric experts across the country on child development to talk about what are the things that go into creating healthy children. And if you look at many of those reports, many of which were authored in Canada actually, the international reports on the early years, many of the seminal ones were authored in Canada, they speak specifically about a quality that is attachment, And if you look even deeper into those reports, they describe attachment in a way that makes it clear that it's actually about adults in any given setting where children are present, providing those kids with love. Full stop. You do not need a credential for that. And so I had this conversation with Dr. Robin Williams, who some of you may know. She's well recognized as an early years expert in Canada, and has actually won the Order of Canada for her work on the early years. And what Robin said to me was, Gaynor, you can't write a prescription for that. And I would say you can't write an app for that either. So there are some of those tacit pieces of wisdom and capacity, sort of in our communities that I think absolutely have room in sort of our evolution of the healthcare system.
Nora Allen.
Hi, my name is Nora Allen. I'm a first-year Master of Public Administration student here. My question is for Dr. Watson-Creed and Dr. Vaughn yet again. We talk a lot about technological innovation, biomedical innovation. It's good headlines. It's digestible to the public. But I want to know what you see as the future and of innovative public health, innovative prevention, because I don't think we talk about that as much. And it's not, as good a headline.
So this is where we converge, I think, Gaynor and I. By the way, I'm a preventive medicine physician, just like Gaynor is, and so I have a bias to that for a good reason, having been, in various areas. But I think ultimately, if we can look at the kind of social innovation that solves many of our problems, the kind of social innovation that I think is being talked about in large part around basic income, I think is fundamental. There are other things too, but I think the basic income conversation is such an important conversation around the things that we have been talking about, both in terms of data, in terms of outcome, real health outcome, and not expenditure on the sickness business. But it gets into many of the social determinants of health. And poverty is one of the biggest issues. It worries me, particularly in the world we're heading into with increased automation and dislocation of jobs. We're starting to see some of that globally now, and it's nothing to do with globalization, but it's more to do with the changes of the post-industrial revolution, whatever moniker you want to put on that. So I think social innovation to me is around today, basic income being one of those, and there are others that we need to talk about, including legislation around human rights in the digital age, and access to internet is a basic human right. Those kinds of things I think are important.
No, I think he said it.
Okay, we've got some time for questions from the floor. This lady right here in the black dress.
Hi, my name is Sarah. This is on, yeah?
Yep.
I'm wondering about, given that we're discussing policy and we're also discussing innovation, I forget this a lot, but 5 years ago, my phone didn't have apps. I had email on my phone, and I was the only one of my friends. And when we're looking at the review process for medical technology, like we're looking at a 5-year turnaround, right? So if we're looking at things that are actually going to be effective in this way that we're hoping that they will be, is there any discussion around adjusting policy expectations and adjusting kind of review expectations, or implementing a different process for technology or software that would make those innovations able to happen sooner and actually have an effect on the population?
And is that for someone in particular, that question?
I think the technology question has come up with everyone on the panel, so I don't need to address it to anyone in particular. I think Dr. Vaughn has been the most vocal on technology.
That's why. I'm hoping to get a couple of questions in, that's why.
Who feels strongest about it?
It's a great question, and I don't think there is, a simple answer to your question. I think that much of what we're seeing is an evolution of the integration of biology and technology at a faster pace than anyone has ever believed or seen before. And so there's not an institute that's sort of got that in tow. There's the Maersk Institute in Denmark, probably the one that comes top of mind, that's doing probably a better job of the evaluation of those tools in terms of your question, but there are probably others. I just didn't want, that's one that comes to mind. We don't have anything locally that I'm aware of. You know, most of this is that sort of black hole thing. Most of the challenges, I think, are fundamentally limited by our thinking. If we're still looking for descriptive analytics to solve our problem, it's like waiting for the stock market results 5 years from now. Nobody wants to do that in this environment. So the real-time opportunities, I think we're going to have to create that in this environment as they are in other places.
Catherine and Richard, headline answers only, because I want to try to get a second question, if I may. Catherine?
Okay. I think in terms of thinking about the influence of data, you also have to look at, if not the dark side, because I don't want to go the dystopian route too much here, but also, you know, where is the resistance to the use of data? And I think, for example, that physicians as a group are somewhat threatened by the fact that there is all this data out there, so that, you know, to a certain extent, policy making can be made by looking at the data, and it undermines the expertise that a lot of physicians have. So, you know, I think that physicians quite rightfully are a little bit wary about where this will take them. So rather than saying simply how to make these innovations happen sooner, it's also important to identify where the pockets of resistance will be, for good reason.
Richard?
Same point. We have to look at systemic bottlenecks. You know, look at Obamacare. One of the greatest obstacles to the rollout was a website. And in New Brunswick, we still have difficulty having a single electronic records for patients. So how do you bridge, you know, this age of acceleration and dislocations and all of that with the fact that we still seem to be like dinosaurs in the public sector in terms of adopting that technology? So there's a systemic capacity to adapt, to change, that we have to look at. And this, again, to me, you got to look at the insights of political science to try to understand why is it that we can't do any better.
Another question. Sir.
I am Abdul Kente from the Gambia. I am also a student the MPA program. I would like to shift us to a little bit outside Canada, just with some practical examples regarding how effective or helpful public health intervention programs regarding prevention, and even with a few epidemiology approaches, can help. There's a saying that an ounce of prevention is worth tons of cure. In the Gambia, from late 1980s to the whole of 1990, about 2/3 of our health budget goes to malaria, curing malaria. You know, there were a lot of morbidity and mortality rates, you know, among children under 5 years, and even pregnant women dying because of malaria. One of the strategic approach that worked very well was the prevention method. You know, Gambia has moved from the pre-elimination stage in terms of malaria prevention to elimination stage. So we are very close to eliminating malaria completely from the Gambia, thanks to not only the work of the clinicians, but also behavioral, you know, public health, behavioral, social and behavioral sciences approaches in terms of behavioral. We have models such as behavioral change communication, communication for behavioral impact. These are some of the approaches that worked very well. I understand when we talk about prevention models, we attribute most of the WHO findings and you know, models and approaches to developing countries that probably they need most of the prevention mechanisms, because probably they have strained budgets to take care of their healthcare systems. Hardly do we think about such approaches can be very helpful in the context of even what we call developed countries. So mine is, I would like to incline to my colleague, is it John Joe? The name again, the last one there.
Watson Creed.
Exactly, yeah. So that is very impressive. But finally, I've learned from the presentations that if 20% of the health budget, of the healthcare budget, only 20% goes to the clinics, for example. And from the other part of the argument, you could realize that about 5% goes to kind of prevention initiatives. Where is the rest of the budget proportion going to? If this is the case, you know, I am a little bit. I am not very clear as to if bulk of the money is not going to the clinics, and it is not also going to the prevention initiatives, where is the rest going to? Thank you.
Great, thank you. Who wants to?
You're probably in a better position to answer that than I am.
So, roughly 70 to 80% of all the budgets go to pay people's salaries, doctors and nurses. And others, you know, other people. So it's going to perpetuate, well, I like to say the status quo. Not that they're not doing good jobs, don't misunderstand me, but that's the, you know, what we have historically, a system that's very driven by individual practice. And that is, you know, we spend most of our money on hospitals, which is mostly people in those hospitals, doctors and nurses. And then we have doctors and drugs competing. And that's the bulk of the budget. Then you get 1.5% for public health. There's not a lot left over at the end of the day. You know, there's maintenance, there's infrastructure, there's insurance, there's all those other things.
Any comments on prevention in developing nations? Was kind of the preamble to the discussion.
Well, yeah, I mean, you know, the paradigm that I mentioned, primordial prevention, actually came from a WHO cardiologist in 1978 who said, in the developed world, we seem to have missed the boat around prevention. By that point, we were well into what's known by the Institute of Medicine as the era of chronic diseases, which is where we are currently. Chronic and emerging diseases now, we would say. So this cardiologist actually looked at the burden of cardiovascular disease in developing nations and said, so if we've missed the boat in developed nations, what's the opportunity for us to actually look at the developing world as an opportunity to create societies where those risk factors for chronic disease simply don't exist? Now, some of the challenge, and I think some of the reason why that prevention language becomes difficult to incorporate is that when you say it that way, it looks quite daunting. And so I have had people say to me, that sounds a little bit like chasing rainbows and unicorns. But then others who would say, well, you know, we've kind of done that with tobacco. So we now have entire generations, for example, around the world who actually can get to the age of 15 and not ever have seen a tobacco product. That's a success in terms of prevention. So, you know, I think it is a model worth looking at. I think where we have applied so much scrutiny to it in the developed world, as per Dr. Strasser's kind of edict in 1978, we do need to pull back now and look at what are we missing in developing worlds. We've done that. We now need to look at what do we need to do in the developed world to get ahead of the curve that we've created in chronic diseases.
Thanks so much. We've come to the end of the panel time. Of course, the panelists will be joining us for a roundtable discussion at the MacEachen Institute this afternoon, chaired by Daryl Dexter, and we'll look forward to further discussion at that time. I will offer them a token of our appreciation at the time when they're at the MacEachen Institute. For the time being, please join me in thanking our panelists for an excellent discussion.